Okay. Good evening, everybody. First of all, I'd like to thank Mr. Habib Gamra for organizing Pafcic 2020 with his astonishing group. Actually, today we have an important session with Africa Fellow Summit about PCI. It's an honor for me to have chairing the session Dr. Rashid Bishna, Dr. Mohammed Jailan, Dr. Maburi Dar, Dr. Ahmed Sufyan, and Dr. Habib Gamra. The objective of the left main is to know why you are using PCI for left main is in comparison to cabbage. Actually, after syntax of the trials, now we have the carriage and then do tips and tricks and do different cases. Optimization is in need, is imaging is the must. Then types of stenting, one or two stents, heating is essential or not, and then the different types are leak, rush, and tap. I think this will be a 1.5 hour. Need your listening, maybe your questions, and Dr. Rania Hamel of moderating the question. I'll be the first speaker. If you allow me to share my screen now, and to be the first speaker, Dr. Habib and Dr. Awad asked me to do our colleagues to these questions. Why should we continue to PCR left main? I asked myself how to make this. Actually, I have the agenda. I'm not 10 minutes. I will try to finish 10 minutes. The guideline left main stenting, which is last one, 2018. Criticism of the conduct Excel trial in BBC News, the rumors about night program. Early and late outcomes of left main PCI, and why Excel is so controversial. Is it important to identify the pre-procedure myocardial infarction is clinically relevant? The rule left main PCI and after Excel Nobel, and then my final thoughts. These are the guidelines. Actually, it's very simple. Left main PCI, Tentex 0 to 22 PCI and cabbage class 1A. Syntax 2332 is cabbage class 1A, PCI 2AA. Syntax score more than 32, cabbage class 1A and PCI is 3B. But actually, I think this is an important slide coming from the guidelines about some technical aspect favoring PCI, clinical and technical anatomical. Clinical characteristic presence of severe comorbidities, not adequately reflected by scores, advanced age, frailty, reduced life expectancy, restricted mobility and conditions that affect rehabilitation, and also some anatomical, like anatomy likely result in complete reversal, the poor grafts, poor quality of the graft with distal runoff, and multiple disease with syntax score 0-22, severe chest deformity, secondary chest radiation, scoliosis, and porcine aorta. But actually, these are some rumors coming from David Taggart, which is also one of the investigators of the Excel, and this is in BBC News, and this is the signatures of the Excel leaderships on behalf of them that this is a rumors, it's not right. Taggart said that non-inferiority for 3 years, so why do superiority analysis for 5 years, but finally he found the solution for this. Early late outcome, remember with the Excel when it started at 5 years now, it's no difference in all-cause death, stroke, and myocardial infarction at 5 years. If you compare the most important trials, which is the Nobel, Syntax 5 years, Syntax 10 years, 2019, Excel 5 years, 2019, Precompats 5 years, 2015, and 1 year 11. This nothing difference for all-cause deaths between PCI and cabbage. And compare all of this for 5 years, Syntax, Precompat, Nobel, and Excel, also no difference in long-term mortality between PCI and cabbage. The same for the cardiac death, the same for the stroke, the same for the stroke in general, no difference. But when you come to the updated meta-analysis for these five randomized trials, and 4,600 patients, mean follow-up 5-6 years, regarding what's known as procedure MI and non-procedures, which is claiming of the rumor of the Excel trial. Actually, if you have procedure MI, there's no difference, but you give no non-procedure MI, actually cabbage is the winner. So why Excel is so controversial? It comes from the beyond the science that is mortality is greater after PCI compared with cabbage in the left main disease? And if so, does not this thrombol? Number two, why was the specific protocol definition in the universal definition rather than SKY definitions? So they claiming that the 5-year mortality in Excel difference was modest, and the mortality was underpowered exploratory endpoint, and this observed mortality difference in Excel real. It's the truth. And to improve the precision, low frequency outcomes in death and MI stroke must look at all quality randomized chronic trial data. If you look at this individual patient analysis for the 11,000 randomized patients, 38.9 with left main disease for all cause mortality, there's no different PCI in cabbage. Whether diabetic or non-diabetics or different syntax for the 5-year long-term mortality, with the meta-analysis, for the syntax left main at 10 years, no difference. So what is important now? What's important? The claiming of peri-procedure MI. It depends on the definition. Actually, the background, the definition of peri-procedure MI differs in troponin versus CKMB, in different thresholds, in the need of adjunctive findings, wave of clinical evidence. The prognostic impacts of this MI after PCI continues to be debated. Do you use SKY definition or universal definitions? And this is the SKY universal definition. Look at this difference. So you look at the 3 years clinical outcome, the pre-procedure. If you have pre-procedure infarction, yes, all-cause death is 14.5 versus 6.5. The cardiovascular death and death is more, but non-cardiovascular death, no significant difference. For the 3 years cardiovascular death, the peri-infarction with the cabbage PCI is higher than non-peri-infarction PCI in cabbage. If you take the CKMB effect and troponin, yes, if its level is high, there is mortality is more. If the biomarkers level will cause death, yes, as you can see at the yellow here, it's high. The Excel definitions, if you have procedure definition, what's favor this? PCI is 3.6%, while the cabbage 6.1% for the death. If you have third universal definition, 2.2% for cabbage and 4% for PCI, if you take universal. So they conclude that for left main intervention, SKY definition is clinically relevant. It predicts cardiovascular and total mortality, predicts cabbage and PCI. Universal definition less sensitive for cabbage, but predictive. And universal definition more sensitive for PCI, but not predictive. What's the role of left main after Excel? This is table show the difference between Excel, famous Excel and Nobel. If you see this, that the number of centers is more in Excel, number of countries more in Excel, syntax is less than 32 in Excel, no restriction in Nobel, endpoints more in Nobel for revasc other than death MI stroke. Pre-procedure MI, yes, in Excel, no in Nobel. For designs, there is a biometrics. 3 years stent thrombosis is more in Nobel. Definite stent thrombosis is less than symptomatic graft is more in Excel, yes. Stroke is more in Nobel. Worse PCI with the higher syntax, yes, with Excel, no in Nobel. So what's Greg Stone said? This is a slide from Greg Stone that the left main revasc with the low intermediate syntax score, cabbage for PCI, contemporary DS, mortality is similar, PCI cabbage, stroke is lower PCI, MI is lower PCI, pre-procedure endpoints, higher PCI during third follow-up, similar through 5 years, short-term morbidity, less with PCI substantially, revasc less with cabbage than PCI, 5%. So he's claiming that PCI with contemporary DS, especially designs as proven in Excel, may be considered acceptable, even preferred revasc modality for selected patient left main disease, a decision which should be made after hard team discussion, taking into account each patient individual circumstance, and yes, I do think PCI should be class 1. Finally, my final thoughts for me and my mind's eye and I, that in PCI, early advantage, yes, less invasive, fewer procedure complication, lower 30-day MACE, more rapid recovery with better early quality of life, early angina. Cabbage, late advantage, more durable, fewer adverse events beyond one year, particularly in repeated VAS. But so when you get taking PCI and cabbage, no significant major difference in long-term survival or MACE, death, MR, stroke, or quality of life. So PCI comes to stay in left main cabbage. And final thoughts coming depending on theory and practice. And thank you very much. Any question?
Ahmed, thank you very much. It was a great talk. Just you're talking with the voice of Greg Stone, and Greg Stone. I mean, he's the promoter, and he's maybe one of the people who were not in agreement with David Taggart, because there is clearly a conflict between the two. Because actually looking at the data, that's what we have shown us. At 5 years, there are 38% increase in mortality with the PCI approach. Of course, if you try to refine the statistics, you go into the details, you try to change the criteria, etc., you would find that with cardiovascular death, particularly, there is no difference. But still, I mean, the trend is that cabbage is most likely superior, and it was clearly shown in Noble. So I don't know. I think we have to be a little bit objective and say it is true that cabbage, when it is well done, and particularly as you mentioned in a subset of patients, it is a winner. And you know, we're interventional cardiologists. We love to do that. We love to do left main PCI, but we have to think of our patients and what is best for our patients. So I don't know if you
I will answer.
Have a chance of comparing these two trials.
When you asked me to this, I looked to the different opinions, whether Greg Stone or non-Greg Stone. Actually, then even the part, you know, the part is first man to do the left main, not the Greg Stone. Then come the group of the Greg Stone. Then coming the pre-procedure infarctions and the rumors. So I collected all the data. I know that Greg Stone is with. And since the syntax, now you looked at the syntax 10 years, Habib, you found that the syntax in the left main, the left main, originally the left syntax trial, the left isolated left main with single vessel, PCI is better than cabbage. I know that with 2 vessels, 3 vessels, even with the guidelines, old or recent, yes, cabbage is the best. So I'm speaking about the low syntax and intermediate syntax. I'm not speaking of the high syntax whatsoever. If you have a left main isolated, have a single LAD, the PCI, the cabbage. Like, for example, the proximal LED. Yes, Lima is the best, but nowadays, with a good stance, PCI equal to Lima in the long term. So I'm speaking about a simple left main with 1 or 2 vessels, actually. And there's no difference between diabetes and non-diabetes, as you can see with the comparison of different trials. But if you collect all the trials, yes, it is the same in the syntax 2020. It's not class 1A in more than in intermediate, but it at least is 2A in 2020. So it comes to stay with the newer generations and what's known as PCI optimization, using IVAS in some cases. The same like the cabbage. You know, the best centers, not all the centers can do cabbage better than the PCI. So depending in our situation in Africa, at least, we are intervention. You look to the quality of the center. If your quality of the center is great and with the comorbidities is less, yes, go for cabbage for the 3 vessels or the 2 vessels. But if their quality is less than intervention, go for PCI. This is my opinion. I'm doing this in my center, either the private and even my university.
Jamal.
Yeah, in this discussion, I think we are forgetting one important thing. The patient who is having coronary angioplasty is out of the hospital the next day. He's in a lot of time, he doesn't stop smoking. He doesn't change his way of life. The patient who has a cabbage change his way of life 360 degree. So his risk factors are controlled. He is not the same patient. And if we want to compare cabbage to angioplasty, we have to compare everything. So our patient should go for rehabilitation. Our patient should go for, and then you can compare. And I'm sure that this part of the field is not well studied.
Development of atherosclerosis, yes, I agree about this. Atherosclerosis, it is the same. You see, nowadays I'm doing a lot of cases after cabbage, which is sometimes difficult to do, to open a native vessels rather than to open the grafts. So atherosclerosis is a progressive. It comes even sufferers graft patency is within 1 year. The surgeon usually tell us this takes 7 years. You know, it's not taking 7 years in different. The way of harvesting is, I didn't give you a slide showing that the guidelines, even the surgery, depending, you have to have a Doppler for the flow. You have a radial artery, you make it in the high-grade stenosis. You should do good harvesting of the vessels. So I think the advantage of the cabbage should be go hands in hands with the PCI, the new technology. Regarding the lifestyle, yes, I agree completely. It will the same with the cabbage and PCI. I think we can go to the next speaker because of time, Habib. Well, if any questions, if you have any more questions.
Just I agree with you, Dr. Subhi, about the availability of surgery centers. So in emergency, sometimes we have not a choice to make the vascularization of the left main. Sometimes we have acute coronary syndrome, complicated left main, and the surgeon are not available or surgery center. Then we must make PCI on this patient. I think in Africa it's a problem of availability of emergency surgery. It's the problem.
There is no cabbage in left main STEMI. I mean, no cabbage in left main STEMI. Left main STEMI is PCI 100%. You should open the artery, whatever. I mean, even in the early era before DS, I do this with the bare metal stents. I open the artery, I put a bare metal. I know that the statement of my boss, Spencer King, past president of the American College of Cardiology, that Muhammad, restenosis will not kill the patient, but emergency is very important. Should open the artery by any mean, by any mean. Yes, I agree completely what you said. Yet emergency, you need to open the artery.
Yes.
But I'm speaking about the elective cases or acute concern that's patient of non-STEMI, but maybe you take 1 or 2, 3 days to discuss with the heart team.
Yes.
With the heart. Yes, I agree completely. Also, we discussed you should have a heart team for those patients with left main and the multivessel disease. Very, very important. Sometimes it's missing in our region, but I'm trying to do this in our country, in Egypt, in the insurance universities, in our private sectors. Usually, I'm asking most doctors don't do ad hoc left main except in emergency. This is very important. And then we discuss, as we said, the lifestyle, the affinity, the frailty, and then sometimes it's a frail patient, and you have to do a left main with multivessels. Sometimes you do what's known as selective angioplasty, not all, if you have a high Euro score. So it depends patient by patient. You take your assessment for doing a left main. But in a way, left main is easy bifurcation than left main. As Dr. Awad will say us, will tell us when his case, it's a safe trip, Dr. Awad. I know that tips and tricks with your case. I think we can go now to the second speaker. The second speaker will be Dr. Awad Muhammad, safe stenting of the left main tips and tricks. Can you share your screen, Dr. Awad?
Very good. Yeah, thank you very much, everybody. Thank you to Tunisia and Pafcic team. I would like to say a word from the Bhaskar perspective that we're very happy to join Pafcic, as Bhaskar is an integral part of Pafcic, and Pafcic has been our gateway to Europe and America. And thank you to Habib for that. On behalf of Bhaskar team, I say thank you for the opportunity. I will share my screen now. You won't be able to see my face, but we'll go to the presentation then. I hope you can hear me now.
Yes, we hear you.
Okay, so the screen is coming up. Now, can you see my screen, Mohammed?
Yes, it's ever. Yes, learn how to survive the steps. Yes, go ahead.
Okay, so we have now BASCI. BASCI is a Pan-African Association of Structural and Coronary Intervention. We haven't passed our first birthday yet, and this is a new association addition to BASCAR. I would love every one of you to have a look at it and join, please. The other thing I would like to draw your attention, the name of my presentation was Tips and Tricks, but since this is an African Fellow Summit, I added to it learn how to survive the steps when your boss is likely to take over. You know, doing left main stenting, as Muhammad Subhi alluded to, is an essential part of our work. Although surgery is getting the advantage at present, but we have come a long way towards surgery when we will take over sooner. But you have to do some left main intervention. Sometimes there's no other way out. So in doing that, during your training, you will have to be the primary operator most of the way the training is. But we all dread the moment when your boss push you aside and you have to leave the driving seat and to be an assistant. And there are certain particular moments during the procedure, your boss hands are itching and he or she cannot withstand you for long. They watch, and the moment you flip, they will take over. So in these few minutes, I want to show the fellows that those crucial moments in time during the procedure that you do not want your boss to step in. You have to be careful at this particular. You see this picture, big decisions like when you want to do only the ostium or you do the entire left main, you want to do one stent or two stent, all these decisions are made when everybody is cool and there's no problem and your boss is quite happy to hear you all the way through. But the moment that you need to be wary about is when crucial point at the procedure. Before I go on further on these moments, I want to draw your attention to this publication we made as BASCAR in conjunction with Goran Stankovic and Tijan Miliskovic and other names you can see. I'm very proud to be part of this. Please refer to this. You just Google it step by step manual. It's published in 2017 and early 18, and it was the most downloaded document then. So now to go to this step, the first point in the procedure when your boss is ready to jump in to take over from you is when you're putting the stent in the ostium. The left ostium stenting is not for the faint-hearted. Look at this. It's you need to choose the right projection. Usually, you can see this one, you cannot see exactly the demarcation between the left main ostium and the aorta. This is a LAO, usually 20 and 20, LAO 20, cranial 20 is the best view to see this. You can clearly see this is not, and we will highlight it further, this stent is not in an optimal position. And if you continue on this, is the likelihood of the boss taking over is very high. Look at it. The roof is here, it protrudes into the aorta, so you would want your stent to covering the roof when you accept some protrusion at the bottom, because the lining up of the roof and the bottom of the left main are not the same. So you have to summon enough courage to pull the marker way out to cover the roof and accept some protrusion in the the bottom. This is because you can see the way it is shaped. It's not at the same plane. Look at it, and now look how it's made. This is the Visible Heart project from Minnesota. This is the right coronary ostium, and as we take around, we show this is the human heart, human aortic arch. This is the left main stem ostium, and you can see how it's shaped. This is the aorta. This is beautiful program from Minnesota, the Visible Heart Project. You can Google it and enjoy the amazing views because you can take pictures through this fluid. It's not available as a test, unfortunately, but it is available as educational material. This is the actual human aorta. And look at the ostium of the right, and as we turn around the ostium of the left, they are not in the same plane. So you have to tend to cover this, and you accept the stent is hanging out here. And hanging is what the next spot we're going to talk about. So this is how it is. Now, the second important point in this intervention in the left main is the pot. The pot has been declared by all interventionists the best maneuver over the last 15 years. It was first described by Olivier Demont in 2007, and it has changed the face of bifurcation intervention. Look at how it's done. You usually take the stent up to the distal, the daughter branch. In doing this, you leave this part, malopposition, because you choose the stent according to the daughter. This one has to be corrected, and the way it is corrected is through the pot. Now, for the pot, you have to gel the wire. There's no bifurcation intervention without gelling a wire. For the pot, you have to stop here, to stop at the carina, taking a bigger balloon. This is called the pot, and this is the proximal pot. These are essential procedure, and your post is likely to take over, because if you go further, you do the first mistake of carina shift. The carina shift is what occluding the circ. Usually this is the circ, and the patients do not tolerate this well. The patients will go in hemodynamic compromise immediately, and you lose your driving seat and you be an assistant. So with the pot, you have to know where to stop. To stop the marker, you need the shoulder of the balloon. The shoulder of the balloon, according to different manufacturer, lies in different places. Before the marker, and sometimes in front of the marker. So this is how the pot is done. This is the size of the daughter. You leave this spit has to be done. Pot and then proximal pot. If you do this, the procedure is gone. The patient blood pressure is down. The monitor is speeding. The boss is in the driving seat. You have to be well trained in doing the pot, because it makes an awful lot of difference if you get it right. The next patient, the next stuff is, you know, the marker, the shoulder is what you need to be in the carina, and this is how you do it. Different manufacturers have this Boston, Abbott, the marker, the shoulder is before the marker. Here, the shoulder is distal to the marker. So you need to know your stuff before you get yourself into this. The next point is you have to get a distal stent. You should not tell me that you will be happy only if you recross. Anywhere will do. No, anywhere will not do. You have to get a distal strut. And it's easily demonstrable. If your wire comes here, that means you're in a proximal strut. So you have to come here, because it makes an awful lot of difference in the final, the way your stent looks and the way you cover the ostium. Look at the video here. You see the wire. This is the gelled wire here, and this is your wire coming. You can see the distance is quite big. And it's not only be happy that you cross. The other point where your boss is likely to jump in is getting your balloon back. Stents on the LAD are usually big stents, a 3.5 and above. The balloon is bulky. If you pull that balloon back, you're likely to cause longitudinal compression. Now we learn from Excel that longitudinal compression constitutes 7%. And in all 7% patients, that the mass is doubled because of the longitudinal compression. You might not be able to see it in angiography, but it is happening and it is your own doing. So you have to train yourself. When you're pulling this balloon, you have to pull the guide out. You need to pull the guide out before you pull the balloon. This is the same technique for pulling the balloon of the pot of the stent and for pulling the gelled wire. You need this type of situation where the guide is a little bit out of the left main to avoid the longitudinal compression that it was deliberately there. The stent was deliberately there at the bottom because you cannot avoid the stent not to be out there. When you pull, the balloon is going to get in, and this is where the trouble is. The other thing I want you to make attention, you see this wire, gelled wire. You should always gel the wire in the left main. You should always leave it there when you're doing the ballooning. The ballooning is big ballooning. It's not mediocre ballooning. You really need to get this stent for good opposition. So you're going to put an awful lot of pressure. Do not be afraid. The common question that comes every time in left main stenting sessions, is it safe to leave the wire gel? Yes, but you have to make sure you do not leave this bend there before you inflate the balloon here. You have to straighten your wire so you do not get in trouble when you're pulling your wire out. Look at one of the masters of Thierry Lvov. Look at him pulling the gel wire. So you see the hand, his hand is fixed, holding the guiding catheter while pulling the wire. You should look at the hand and at the same time looking at the screen. The gel wire comes easily. The guiding catheter did not move an inch. So you fix the wire to the patient's leg or hand, and you pull back your gel wire, avoiding longitudinal compression. The other trick I want you to know is getting a balloon through a stent. This is if you can see this is the stent into the circ, into the left main, into the LAD. This is left main, LAD. And this is, can see here, this is a balloon. And Jem Fajade is trying to get from the left main through the stent strut into the circ. This wire is in the circ, and this is the common scenario. All the time you fail to push a balloon through the struts of the stent. And look how he does it.
To cross. Interesting. Yeah, you see. Yeah, it's negative.
See, he cannot push. So you press hard against the stent, you inflate, and deflate, and push again.
Sometimes it's working.
Yes, inflate.
And then we push.
Look here.
You see? Yeah.
Deflate and push again. Did you see that? I hope I demonstrated that well. But the idea is this balloon here did not cross the struts of the stent going into the LAD. So what he did, he pushed hard against the strut, inflate and deflate, and then push again. Just the tip of it is within the strut of the stent, and that usually can bail you out. So in conclusion, the tricks that you need to know about the ostium of the LAD, cover the roof and leave the stent hanging in the bottom. The bot is the most important intervention in the last 15 years in the bifurcation. It changed the face of bifurcation thanks to Olivier Dermot. The other thing, longitudinal compression, you have to be very, very of it. Is a very important technique that you need to know about. And the other thing, getting across a stent in the left main into the circ, and that is the technique Jane Fajade has demonstrated. I hope I showed you some tricks that you need to do for safe left main stenting. Thank you very much.
Thank you, Howard, very much for this nice safe trip. Yes, I like this the name of safe trip. Actually, I want you to illustrate to the fellows your decision about the left. You have now LAD and side branch circumflex. What is the opportunity of the CX at the key artery for doing one stent, two stents, and the angle and the different techniques you choose according to this angle and the side of the CX?
Yes, this question is very nice question, and it's the headache of every interventionist, but it's usually one stent strategy would work, even for the left main. But we usually try to go to two stents in the left main. In this provisional stenting, when you put one stent, the results as per published data is as good as two stents, even in left main. The only difference when you want to put another stent is when the side branch on its own merit warrants a stent. Like if you cut off the left main and the LAD, you know this need stents. Take the circumflex on its own. Would you do a stent for the circ on its own? If the side branch on its own warrant a stent, then you're on for two stent strategies. But if the ostium is okay, then one stent would do as good job as two stents would have done. I hope you answered your question.
Yes, very, very good questions. For the ostial and body, you do direct stenting with a short stent to the ostial and body, or you go to the left main, or stent crossover to the left main or the CX? What's your policy for the ostial and the body?
I know the evidence say you may leave the stent up to the mid of the LAD, but personally, I like to cover from the distant left main to the ostium of the left main, because I'm going to be doing a lot of pot, high inflation, and I do not want to be thinking about the mismatch in the left main. So I prefer to go all the way to the ostium of the left main. Then I have the liberty of good opposition, big inflation with the bot palm.
Any questions from the chairman here? Okay.
Yes,
Yes, go ahead.
Yes, thank you very much for this presentation. I have just two questions. Just in the case of distal left main stenosis with a long left main, do you choose to stent the whole left main or to use a short stent? This is my first question. And my second question is about the type of the stent. Do you consider the results of Excel and Nobel studies when you choose the stent? I mean, do you prefer to use Xience to biometrics, or you don't care about the type of the stent?
No, I do care. Let me take the second question first. I do care very much about the type of stent. You would want a stent that can go the whole way to fill the left main. So then you need the open open cell design that you can inflate like in the resolute integrity, and can go as big as 5.5 or even 6 is the sky is the limit. With the new stent now is even easier. So you need to choose a stent beforehand that you know this stent would go the distance in the left main, 5.5, because left main are usually big. As for the first part, I think you just missed the answer that I prefer, if the lesion is localized to the distal part of the left main, I would prefer, although both the types of your answer work, but I would prefer to go all the way to the ostium of the left main, because the disease in the left main, you might not be able to appreciate it in the proximal half. You know you have a problem in the distal half, but if there is a problem in the distal half, almost always there is a problem in the proximal half, but you might not be able to appreciate it, especially in this part of Africa, where we do not use IVUS in many countries. So I do not know what is going on the proximal part. This one. Number two, if I were to leave the stent halfway in the left main, I might not have the liberty to inflate, because if you want to expand the proximal part of the stent, some part of the balloon might be just outside the balloon. This will give you a mismatch, and you do not want that in the proximal part of the left main. So I prefer to go all the way, then I have the liberty even to flare the stent where half the balloon is in the aorta, and in that part I'm comfortable. The data, there's no such significant difference to make you choose one way or over the other. They're equal in terms of mace. What makes a difference is the bot. Bot made an awful lot of difference in the way we do.
Thank you, Dr. Awad, because you are coming late. I'm sorry we have to shift to. Thank you very much. Very nice lectures and discussion. Now is imaging essential, IVUS, OCT, or just fluoro? And this is by Eduardo Kamenzait, the famous intervention cardiologist in the world from France.
You're a bit ironic.
Hello? Yes.
You hear me?
Hello, Kamenzait, go ahead.
Okay. Thank you very much for the invitation. First of all, Habib, congratulations that even COVID didn't stop Pafcic to go through this year. So congratulations, really marvelous job.
Can we hear you more? Can you raise the sound, please? Because your sound is distant. Yes, okay.
As long as I can
Yes.
hear me
Yeah.
back.
Yes, okay.
So actually, what this title implies is that the question is utility of invasive morphological assessment in left main PCI. That's the key question that we are trying to answer. So basically, we are comparing angiofluoro to IVUS or OCT. These are the two intravascular modalities. And indeed, angio and fluoro are quick, standalone technique, needs no wiring to have already a message concerning the luminal aspect of your vessel. And the big advantage of OCT and IVUS, these are excellent 2D sizing of the lumen with those two methodologies. And indeed, you have better tissue characteristic of intraluminal material, as well as the intravessel wall material. So that is a big advantage that you don't have at all with angio or fluoro. There are some disadvantages that you can read yourself. IVUS, you have two modalities, either the mechanic or the multi-array. That's just a technicality. But the main point I want to do is that you have 20 millimeters between the distal tip of the sheath to the eye of the system. When you compare it to the OCT, you have around 30 millimeter from the tip of the catheter to the eye of the system. And that may be something important when you are trying to visualize the left main. As you see here, you have approximately 30 millimeter down the vessel prior you are able to visualize something, and then you can do two different types of pullback, but something else. The key issue is that you have quite a long catheter distal to the eye. If you compare the two methodology, just look what is has a yellow frame. Indeed, Ivers, you have a big experience. It has been here for decades. It is very important that you don't need to do a pre-dilatation for pre-interventional imaging. That is something key for Ivers, that generally it's a disadvantage for OCT because you need a slight balloon inflation to be able to cross this 30 millimeter shaft that I showed you before. And indeed, the penetration in the adventitia is better with Ivers. OCT, the quality of the image is simply outstanding. It's the best we have. However, has some disadvantage that you need contrast to visualize it, and the predilatation that I just mentioned before that you may have to use. For Ivers, not infrequently, images are difficult to interpret because it's a kind of symphony of grace, and now and again you are able to recognize really where the wall starts and ends, especially the boundary between the lumen and the vessel wall. So basically, your intravascular imaging can be used either pre-interventionally to be sure of the treatment strategy, or peri and post-intervention really to optimize the PCI. These are the two fields of actions. And if you go to the guidelines concerning the left main, they say that Ivers can be indeed be considered to assess the severity of the lesion. And that is a key already message. When your Ivers luminal minimal area is below 6 millimeters square, you know that it will need a revascularization because some of us are not always very familiar with these square per millimeter units that corresponds approximately to a 2.75 millimeter diameter. Then when we are speaking about optimalization, you see that in the guidelines, both are mentioned, Ivers and OCT, but it's not the theme of the evening. The theme of the evening is the left main. So when you are looking of a recommendation concerning left main visualization, you find only Ivers because actually there are no data concerning OCT. Let's see which data are available concerning both methodologies. So indeed, I already mentioned there will be very little on OCT, but the Excel trial using the science standard that showed equivalence between CABG and main stenting at 3 years has a sub-study that analyzed approximately 500 patients with Ivers. There is certain numbers have been left out. It's not specified why, but more than 500, it's not little. And they looked why the Ivers was used. So in a certain percentage, about 16%, it was used just to be sure that actually people were treating a significant lesion. Other were using it only for optimization, around 40%, and probably another group of physicians decided, because they had already out their Ivers to evaluate the lesion, not to use it again, to also evaluate the post-stenting result, what is a rather reasonable thing to do. So, and then they asked if actually the intravascular imaging has changed the strategy. And here is interesting to see that approximately 50% changed the strategy thanks to the Ivers imaging. And basically the strategy is to improve luminal size. That is the basic issue, and either they used a larger balloon, they selected a larger balloon to post-dilatate, or indeed the post-dilatation was again performed with a larger size, they were used higher pressure, or they discovered treatment and expansion that again needed for which you needed further ballooning and overexpansion. And then they looked in the Excel trial accordingly to the size of the minimal surface area. They divided it in terciles to have approximately the same size of patient in the three groups. They looked at the result, and with a higher surface, bigger diameter, you had less death, MIs, and stroke. And you had also less all-cause mortality and a clear trend towards less cardiovascular mortality. And that seems to me a very important message, that a higher diameter at the end of the procedure, bigger area, means less clinical events. And if these were the main result at 3 years, if you would have optimized your minimal luminal area to this size, you see you would have been able to perform very well with death, stroke, and MI only in less than 10% of the cases at 3 years. But that is not a comparison of IVUS versus angio. So I'm not able to answer the title I was giving you, showing you those data. It's simply saying that the better the lumen, the better the clinical result. So we find here data from a registry that compared IVUS guided procedure versus only angio guided procedures in the left main stem with more than 11,000 patients, follow up to 1 year. And here they were able to show in this registry data, the retrospective analysis, that IVUS guided was definitely better, had less cumulative incidence of death than if it was only angio guided. That is a significant improvement of survival using this technology. Another registry that is interesting is the Korean registry, who has an area with we're using only bare metal stent, another one with drug-eluting stent, but that's not the point of the discussion. They just looked at 2 categories: procedures, stent-based procedures that were guided by IVUS and those that were not guided by IVUS, and they followed them up until 10 years. And what they could see is actually concerning mortality, that if you were guiding by IVUS, long-term mortality was lower than if you would only guide it by angiography. And that was true even in different types of population and even in the matched ones. And even the composite endpoint showed exactly the same trend, that IVUS guidance was giving a better long-term and really very long-term 10 years outcome. There is one Chinese meta-analysis that looked all trials and registered and whatsoever data is available concerning all-cause mortality, in which it's mentioned IVUS guidance and angiographic guidance, and they were able to show that IVUS guidance was improving all-cause mortality, and in a subselection of trials that was also improving cardiac mortality. So these are rather strong data. If you will look at the second very important randomized trial, the Noble one, that was using the biometrics stent, then and the results are here, that surgery was doing better than PCI in this trial at 5 years. This trial had also a sub-study using IVUS, and they compared 160 patients that had only angio guidance versus more than 200 patients that had angio plus IVUS post-PCI, really for optimization of the luminal area with the IVUS guidance. And what they show is that post-IVUS, 5-year MACE was lower than if you would only use angio, but not significantly lower. Numerically percentage lower, but not significantly lower. You can say maybe it's small numbers, 160 versus 200, but the facts are here that both methodologies seems to be, according to these data, equivalent. And they analyzed also the influence of the surface. And indeed, it turns out again that if you have a more important minimal surface area, so a bigger diameter, on the long term, you had less MACE than if you had a minimal surface area that was smaller. Probably also due to the small numbers, not significant, but the trend is here. So an important trial, it will be this, I don't see the title of my slide here, probably I have to, the optimal left main, okay, trial, which has been starting a few weeks ago, which will be the first trial that is really comparing IVUS guidance versus normal angiography for left main stenting. And this will be actually the trial that will give an answer to the title that I was giving this evening. Concerning OCT, there is at least one information in the literature, the Lemon study, that is available on the very freshly on the site of the Euro intervention. That is a pilot study that aimed to analyze the feasibility and safety and impact of OCT guided left main stem PCI. So that is a very interesting feasibility trial, and they concluded that it is feasible to use OCT, and it performed very well for a left main stenting. So that is an important information because technically speaking, OCT has a better imaging, but has this technical disadvantage of having this distal nose that is somewhat long to be used in the left main. So what are the conclusions? That intravascular imaging, we should not forget it, that we can use it also pre-procedural, eventually to avoid a main trunk PCI in a lesion that is not enough severe. And indeed, that is for certain, and that we have learned already from the Colombo time, that peri and post-procedural setting, an optimization of the deployment is linked to a better clinical outcome. And I think this intravascular methodology is extremely important for diagnostic as well as educational issues. If you have to teach somebody, you show them the images and you quantify them, and then that remains, that really sticks to your mind, that post-dilatation is something useful. What are the practical message? The practical message is that we should not be fuzzling around in the main trunk, because from my point of view, in the unprotected left main, you should always be quick and precise and as simple as possible, but not simpler, because I mean, if you are missing something, if you're making a mistake, the patient can die. So you don't have to think of IVUS first, you have first to think of the life of your patient. And between the two methodology, IVUS versus OCT, I would prefer, currently at least, IVUS because of the nose of the catheter being a little bit shorter with IVUS and being able to interrogate the lesions without predilatation, what you frequently have to do with OCT. Another practical message is that the clinical long term, what is that you have to retain is that indeed, in particular in the left main PCI, the bigger the better is really true. That's it for this evening. Thank you very much for your attention.
Thank you, Kanzait, for this wonderful lectures. Actually, you know that I have two questions to you. One of them is, what is the percentage of using of IVUS in practice all over the world, in general and in left main disease? Number two, if you have an intermediate lesion in the left main, do you advise the IVUS or FFR for such patients? Because sometimes the IVUS, depending on the plaque burden or the ischemia-driven or the resistance. How do you differentiate this?
Very good question. So the first question I cannot answer to you. I don't know what's the worldwide use of IVUS in the left main. I can only tell you what I am doing. Here in Nancy, we are using it generally, frequently, to interrogate kind of doubtful lesion where we have impression it is 50%, is it significant, not. That we are using IVUS very much. We are using IVUS more than FFR in the main stem. If we use FFR, we be aware that you have to do it in both axes, in the axis of the circumflex as well as in the axis of the LAD. Unfortunately, as you have shown us at the very beginning, you have very infrequently pure left main, and generally it goes with proximal LAD or proximal LCX lesions. So the interrogation of by FFR of the left main stem in those more complex lesions is difficult to be performed, and the message is not really telling you anything about the left main.
The second, the what's known as PCI optimization. Do you think that it is best to do IVUS after deployment? Because sometimes it's difficult to cross the IVUS pre. So
Yes.
it's better to have post, particularly that we have a newer generation now, the Onyx, the Zines, Sierra, and we have Altimaster of Synergy. So these can co-app up to 6. So I think it's with even the stent booth. So I think it's better to have it after, not before. In practice, do you think this is ideal, or in every patient you do pre and post?
No, I would. So my main message would really be that I do it pre if I'm not sure that it is significant. If it's significant by angio, very clearly significant with the clinical setting also, then I don't use neither IVUS nor FFR, and I go for the procedure. The use of IVUS post-procedure, I would say here it's a little bit an educational aspect. If you know, if you have a certain, it's a little bit the message that gave many years ago Colombo. Once you know that under-expansion is an issue and that you push your stent with a very strong post-dilatation, that may be enough. If you ask me what optimized may turn out, is probably potentially what will turn out is equivalence. But if you are not trained, then IVUS is really interesting to teach you that actually you didn't do such a good job as you thought. But IVUS really shows you that you have to work more on the lesion to go for a better minimal surface area.
Dr. Aranya, do you have any questions coming from you or any from the attendee? Okay. If nothing, thank you very much, Dr. Kamenzai. Now,
Ahmed,
yes.
just a question to Eduardo. Thank you, Eduardo, for this nice presentation. I have a question, not very much related to the content of your presentation, but tell me what you think about it. We are in Africa, and one of the ideas behind suggesting to you to do that talk is to give us the reassurance that if you don't have IVUS and OCT in your cath lab, is it safe to still perform left main PCI? And whether if you have those new tools, these enhanced geographic visualization tools such as Stent Boost and V's, would that be acceptable? Like everybody calls them the IVUS of the poor. So what would the answer?
So my answer would be, first of all, you have to be aware of the issue that we have a tendency of under-expanding stents, and particularly in the left main. Once you have finalized your procedure with that sensitivity that you may have under-expanded your stent, then you will by intuitively go for post-dilatation, yes? because you are aware that you have not done probably enough. And if you do that, then probably you would have done, you will be doing a good job. But you have to have the sensitivity that just the first shot is not enough, that you have to work a little bit more on your main stem. That is, I would say, the practical message. And concerning the stent boost method are available, I think they are useful for complex PCI of the main stem, of bifurcation stenting, when you have to use a stent in the left main and the circumflex, and the third one and the second one in the LAD, or vice versa, to be sure that the stent is nicely deployed, especially in the areas where they are overlapping. That is probably something useful to be used.
This is the idea of my question to you at the beginning. What is the percentage of IVAS use? You said, I don't know over the world, I'm doing this. But as Habib said, I have already an IVAS in my cath lab, in the university, but regarding the reimbursement, it's difficult in some patients. So I'm depending on stent boost almost always. In the left main, I do post-dilatation. I'm not using any stent, just 2 or 3 stents in the left main. I'm reaching up to 5. I'm using stent boost. I have 2 cath labs in the private and 2 cath lab university. I'm choosing the cath lab with stent boost or stent beast. That's for our circumstances. Sometimes in conferences, I'm using IVAS. I'm not in practice, not every day.
That's very good. And I think because you are an experienced interventionalist, you know that the risk is not to expand enough. You know it intuitively from your experience. So you will be finalizing and working a little bit more on your left main stem. And if you know that, and if you do a little bit working more, it's enough.
Okay.
So once you know that the risk is not expanding enough and you work on your lesion, perfect. It's absolutely, and in the literature, the only data we have from Noble tells you that there is no difference. You have also, it's also backed up by, if you want,
okay. Thank you very much. Thank you. Rania, you have anything? Any question?
Yes, just one question for patient with at high bleeding risk and left main disease. Do you perform IVAS before taking a decision about cabbage or PCI? And do you use necessarily the IVAS when you perform PCI of patient with high bleeding risk, or you just perform POT and then you can stop your DAPT or use short DAPT?
I mean, the high bleeding risk is not something where IVAS will be able to guide me. IVAS will be able to guide me to tell you if the patient needs revascularization or not. If he's at high bleeding risk and you discover that what you thought was significant is not significant, indeed, you have done a very good job by saying, no, you don't need any intervention. That's the best intervention for you, even for, and particularly for the high bleeding patient. If he needs an intervention, either cabbage or PCI, the advantage of cabbage in a high bleeding risk patient is that basically you don't have to give him dual antiplatelet therapy for a duration where you are not certain about, particularly if it's a complex left main with that extend to the circumflex and the LAD. And on the top of that, that you may need a very long stenting of one of these 2 branches.
So Rani, I think the best for this is to have a stent which have trials. You have 3 stents: Biofreedom, Onyx, and Zymes. The Zymes 1 DAPT, which is 28 days versus 90, just in TCT Connect, and Onyx Clear on the global, and also Biofreedom, as you know this. So, and you have a monotherapy, maybe after 1 month, as you know, a TICO trial, stop depth, stop choice. You have a lot of trials, as you know of this. So that doesn't depend. IVAS doesn't show you anything about the indication. The problem is only...
Allow me a comment. There are concerning duration of B anti-aggregation therapy.
Yeah.
Only one trial that has been done able to give an answer. That's the DAP trial. And all the other trials are not powered enough for answering that question. So you are reading lots of things in the literature. You are reading even somewhat strange guidelines concerning a dual antiplatelet therapy strategy. But between us, we know perfectly well that this is not literature that is really solid for answering that question. There is only one trial, and because nobody will be doing more important trials than that because it's too costly and there is no interest anymore.
Okay, thank you, Count Zoid, for this nice lecture interaction. Let's go again to the interesting talk. Case 1 or 2 stents by Dr. Adel Brigada from Algeria. Dr. Adel, 1 or 2 stents for left main.
Thank
Go
you,
ahead.
Dr. Subhi. Dear colleague, I'm very proud to be among you in this session, this digital session. Dr. Habib asked me to speak about this technique, 1 or 2 stent in the left main. So I prefer to illustrate this technique by a clinical case report. My patient was 46-year-old, hypertension, smoker, was admitted in the ICU for STEMI and anterior trouble. Troponin was positive. So we perform coronary angiography, and on the coronary angiography, we see it was a left main distal stenosis followed by proximal LAD stenosis and plaque, small plaque on the circ. So on the second view, we see the distal stenosis on the left main correctly. Then the first question, how should I treat? Surgery or PCI on the distal left main? The guidelines show us there are a place for the PCI in the left main, especially when the Syntex score is well. Our Syntex score is very well in this patient. The second question, did we perform ad hoc PCI or planned PCI? Then, when there are no emergency, when the TIMI-3 flu is good, we can plan the PCI-4, optimize and improve antiplatelet therapy for this patient. The second question is, what will be the strategy? What's the question to ask before left main PCI? Then the first question is, what's the stent diameters? The choice of the stent diameters. And then the choice of stent diameters is according the Finney law. The 3 diameter of the left main, the main side branch, and the small side branch. So when we see this table, it gives us the relative diameter between the smallest ductal vessel and the biggest ductal vessel. Then it gives us approximately the reference diameter. So in this patient, we see that the LAD is about 2 to 2-3 millimeters, the circ about 3 millimeters, then the left main, the stent of the left main will be about 4 to 4.5 millimeters. Then what will be the strategy? 1 or 2 stent? So it's a great question. Then our Medina classification is 110 because we have just plate on the circ. And the guideline tell us that the provisional side branch stenting should be optimal when the initial stent branch and when the side branch is there are not lesion in the side branch. So when we perform, when the second recommendation is class 2A, it's reasonable to use elective double stenting when the bifurcation is complex with lesion on the side branch. So another study tells us that the coronary percutaneous coronary artery using a provisional single stenting is better than two stent. But this is one study. There are another study which tell us there are no difference between one or two stents where there are complex lesions. Then it's preferably to put one stent when we can. An optimal strategy will help to decrease the need of side branch stenting. But two stents can be performed when the angioplasty is complex, and we must develop strategy to make it easy, safe, and effective. But above all, which stent did we perform in this patient? Then we have to look about the maximal expansion capacity of the stent to expand the stent on the left main, because when we put the stent, we have to consider the distal diameter of the LED and the proximal diameter of the left main. Then the stent expansion will be calculated. We have to put the best stent, the stent with maximum expansion. Also, we have to choose the landing area for the distal diameter. Then we have to calculate the distal diameter for the choice of the stent. So in our patient, we have a lady about 3 to 3.5 millimeter. Also, we choose the provisional T-stenting for the first in this patient. Then we stent with 3.5 millimeter stent to the proximal left main. After this is the result, we exchange the wire and perform the pot to overexpand the stent of the left main. So when we put the first step, when we put the stent is best expanded in the distal segment, but it's not expanded in the proximal segment in the left main. Therefore, we must perform a pot. The pot will expand the stent in the right dimension, in the right diameter. So after we make kissing to open the side branch, and this is the result. When we see the result, we look that were a good result on the LAD on the left main, but there are stenosis, residual stenosis in the circ. Is it carina shifting? Then we can't keep this angiographic result as there. Then we go to which technique, what to do in this situation. We choose to add another stent. Then we switch to two stenting technique. Which technique we have to choose? Then there are two techniques for two stenting. Two stent, T-shape or Y-shape. T-shape when the angle is superior to 70 degrees, and Y-shape is when the angle is inferior to 70 shape. So in our case, we have a wide angle. Then we prefer the T-stenting in this patient, and we perform a mini tap in this patient. We stent the circ with 3 millimeter stent. You see here, we perform a final kissing, and here we show the result. There are a good angiographic result, a good expansion of the stent on the left main, and the result is here. So in conclusion, we have not hesitate to postpone left main PCI, and we have to ask ourselves the right question before this left main PCI, and we must have a pre-etaplated plan. to perform left main PCI. Thank you for your attention.
Thank you very much, Adil, for this nice presentation. Ahmed.
Okay, go ahead. If you have a 001 left main, what is your strategy for? Are you doing one stent strategy, or you should do two stent strategy, or you do what's known as precise PCI? How can you do this?
So your main 001 stenosis only on the left main without the two branch.
Ostial CX involving the left main. Ostial CX involving
the left main. Okay.
Still difficult. How can you manage?
Ostial C. So in this case, for the ostial circumflex, it's depending the two artery diameters, the LAD and circumflex.
Supérieur sur les critères, les outcomes très pression dépendante qui étaient en particulier les AVC et la science cardiaque.
Background.
Dans l'étude ANBPE, on avait 6000 patients qui étaient âgés de 72 ans en moyenne. Et là, on a
Can you stop this?
Ask Rania to mute her. Ask Rania to mute her.
Mute the French translation.
Yeah.
Mais là encore, moi, IVET emporte ma conviction chez les octogénaires. Je sais pas.
Or Habib, tell us what they're saying.
Mais pour moi, c'est ça.
Background sound.
Translate if you would like. But where is it coming from?
C'est la tolérance de ce qu'on
مش عارف منين دي.
Et donc IVET, comme je...
It stopped, yeah. Adil, okay. You can answer it, Adil.
Okay, go ahead.
Okay, it's depending the artery diameter. If the LAD and the circ are the same diameter, we can begin to stenting circumflex and to provisional stenting and open on the LAD. Now, if the circ is the most artery, the biggest artery, it's the same thing. Then I think to stenting left main to circ, it's a good choice in this situation. So after if we have a carina shifting, there are another decision to stent LAD.
Because, you know, if you have an ostial LAD in left main, it's not almost always if you have a free CX to do kissing. But if you have an ostial CX, you are going to do stent crossover for left main CX, it's at least 50-60% you have to kiss the LAD. Otherwise, because this is the LAD, it's not the circumflex. So you have to finish either by kissing or do FFR to LAD to see what's going. So usually, almost always, we end by two stent structure. It's not in the reverse for the LAD left main. The second question for you, the angle size. The angle is 60 and 60. Explain to us how to differentiate to the fellows. When you have a sizable LCX, you have 111 Medina classification, and you have 60, less than 60 and more than 60. Which stent you are going to do? Which stent type? One stent strategy, two stent strategy?
So it's not easy to respond to this to answer to this question. But if the angle is too narrow, it's when we choose the two stent strategy, there are decalculation or culotte stenting. But now you speak about circumflex stenosis, or
you are right. Now, if you have a short angle less than 60 and of a size LAD, you advise is culotte and DK crush. And the tap is the second one. If you have more than 60, that's okay.
Okay.
Any questions, Rania? You have moderators of the questions.
So just I have one question for Dr. Adil. Thank you for this presentation. Do you perform usually kissing? Repot after kissing when you perform the two stent techniques.
So the pod is frequently performed. It's mandatory to make pod in the 2 stand or 1 stand. So final kissing or report, when we perform 1 stand technique, provisional T-standing, we prefer pod and report. But when we perform 2 stand technique, it's mandatory to perform final kissing after the report.
Adil, this is an argument of the normal CX, and you have a 1 stand to the left main LED, is to do pot and recrossing and do just gentle massage of the CX to open the struts for the further narrowing. Do you agree about this concept?
Yes, I agree.
You agree? You do everything. Yes. In any case, you should open the strut of CX. You should recrossing, but not, I'm not doing a final kiss. I'm not speaking about the final kiss. Just
okay. Opening the strut of this conflict, especially when the CX is a codominant or dominant artery, because further narrow or further stenosis will be accessible when we open the strut.
Dr. Kamenzoid with us. What's your yes, Dr. Kamenzoid, and then Habib. Yeah. What do you do in the single stent strategy? Do you open the struts, or you leave it like this, or you end by kissing?
I open the struts, and in the philosophy of the conclusion of my talk, I try to make it as simple as possible. So opening the struts is important, I believe, because there is also an afterwards. Also, think of the guy that will have to treat your second marginal who is highly stenosed in 5 years' time, and you didn't finalize your job acutely. That's not very fair. So I think opening the struts you have to do. I wouldn't do on a single stand strategy. I would not do a final kissing because I a risk to do harm to the LED.
So you open, but not kissing in such cases.
And not kissing. Right.
Habib.
Just a question to Adil and to all of you. A patient with a very tight stenosis of the ostial circumflex, extending a little bit to the left main. How would you manage? The diameter of the left main, 4.5 millimeter. The diameter of the left circumflex is 2.5. How do you manage?
Well, I asked Adil this question before. I asked him this question. There's 2 ways. Either do a precise stenting, you do ballooning, you put 2 wires, you just a balloon in the left main, and you put stent in the CX, just some protrusion, and you inflate the balloon in the left main at 4 atmosphere or 6, and you deploy the stent. This one argument. The second, you do a stent crossover, left main CX, if it is more protrusion, if you have a long stent, depending on the size of the stent, if they have a short left main or a long left main. If you have a short left main, you have to make it left main CX, and then final kissing with LED. If you have a long left main, you can do precise stenting or do stent crossover, depending on the length of it. Adil, what's your advice?
Yeah, if you, I don't know if,
please,
Adil, go.
Yes.
Okay, when there are very great disproportion between left main and the circumflex, it's very hard to take a decision. But if the stenosis is not long, is short, we can perform just a stenting of the circumflex, a little protrusion of the stent. But now, if there are a good proportion, now we can stent left main direction circumflex without problem. It's my opinion.
Yes.
I have just a comment to do about this choice of 1 or 2 stent, and you had a nice talk about different stent to use. I just want to ask you about your experience about self-expandable stent. I know that Jamal loved this this option, and I know that this option is very helpful in case of different diameter between the left main and the distal part. So I have just to activate discussion about this.
You will have it in a few minutes.
I have not experience with self-expandable stenting, but I think the others, someone has experience.
Okay. Any question? Thank you very much, Dr. Adil. We are just have the last speaker. I think it's you.
Thank
you open us for the last speaker to have the types of two stents. The types of stents sometimes difficult, but we have to see Dr. Jamil Langer from Tunisia speak about DK crush, tap. He said in his talk, or other techniques. I don't know. Are you going to show us other techniques or just DK crush on tap? Dr. Jamil?
Okay. Do you hear me?
Yes, very well. Go ahead.
Okay. So first of all, thank you, Habib, for inviting me to speak in this in Pafcic. 21 years. It's a long time. Unprotected left main, angioplasty, DK crash, tap, or other techniques, and in 10 minutes. I do not have any conflict with this presentation. And all of you knows that the unprotected left main is a proximal bifurcation with an important caliber difference between the main, the LAD, and the left circumflex. And it's often difficult to precisely assess the diameter of the different part of the involved vessels. IBIS and OCT can help us in this field. Several techniques according to the anatomy, the angle, the size of the vessels. Some will do provisional, other people will do crash, DK crash, and tap. DK crash, 17 steps, very difficult technique, not mastered by most of the interventionalists. TN protrusion, simple technique, but still needs some skills. I think that the debate is actually over, thanks to Dr. Chen, who said that, who proved that DK crash is superior to the other techniques in long-term survival. And that was his Princeps publication. So I'm going to speak to the other technique, the self-expandable stent. This case was done in 2014. This is a 91 years old man with a COPD, and he has a distal left main, as you see in the picture. At that time, we used the first generation of the self-expanding stent, which is a nitinol stent deployed by retracting a sheet. It was not mounted in a balloon. The stent I used was paclitaxel eluting stent. So this is the procedure. We use the 3.5, 17 millimeter stent. Here we are unsheathing the stent, and this stent was having the tendency to move forward. Then we disconnect the strand toward the circumflex. That's first result. And then we stented the circumflex and see how easy is the passage of the stent in the side branch. Finally, we deployed the stent of the side branch, then some kissing technique, and you will see in a moment the result. I think it's here, okay. And this is the result. The second case is a 78 years old female lady with, as you see here, almost a very diseased left anterior descending artery, stenosis in the left main, and long stenosis on the circumflex artery. So here we use the new generation of the stent T6 position S stent, which is a stent mounted on a balloon, but the balloon doesn't serve to deploy the stent. The balloon is used to split a membrane which is covering the stent, and then we have to pull this membrane at the end of the procedure, at the end of the deployment of the stent. This stent is a sirolimus stent with the polymer, and it has a thick struts, 100 micron. So for this case, we predilate This stent needs a lot of pre-dilatation. Then we dilated the left main, then the circumflex. And as you see here, we are delivering the stent. And this new generation compared to the old generation is more flexible. So as you see, this is the result. This is the post-dilatation. It was like this. And by the end of the procedure, it was like that. And you can note that there was no pre-dilatation of the no dilatation of the LAD. Case 3, a male 74 years old, diabetic, left main stenosis, pre-dilatation of the circumflex and the LAD and the left main. Then we used the 3.5, 4.5, 37 millimeter stent, and that was the result. Okay, so this is the result. I think that what it was like this, become like this. Case 4, a 70 years old patient with COPD and 140 kilogram. He has an ostial LAD. For me, an ostial LAD with ostial circumflex is a left main because once you put a stent, you cover the left main, that become for me left main. So in this case, and you see the angle is very wide, pre-dilatation, stenting with a 3.5, 4.5, 37 millimeter balloon stent. And you'll see in a moment the result. You see, you can compare. This is the final result, and it was like this. Case 5, 53 years old lady, stable angina, the proximal LAD, ostial LAD almost. As you see, this is pre-dilatation, then stenting with the self-expandable stent, 3.5, 4.5, 22 millimeter. The post-dilatation, I think, disconnection of the circumflex strut, and that's the result. Okay, that's what you see when you do a boost. You see, this is even before any post-dilatation. This is what after just disconnection of the side branch strut. You see the size of the self-expandable stent here and the size of the stent in the branch. This is a microcomputer tomography of a stent, self-expandable stent, and you see how beautiful is this stent. There is a study. The most important study in the field is the trunk study, which was a prospective non-randomized multi-center study assessing the long-term safety and efficacy of the self-opposing sirolimus stent. There was 205 patients. The mean Syntax score was 20. And the procedural detail that's important, in almost majority of the cases, there was a pre and post dilatation. Both was only used in 56% of the patient and kissing only 26% of the patient. The side branch opening was done in 3/4 of the patient by balloon, and the side branch was stented only in 26% of the patient. The angiographic success was 96%, and final complete apposition by IVUS was 98%. The results are comparable to the other techniques, and there was no late thrombosis. This is the centers. So in conclusion, the use of self-expandable stentis exposition as in the treatment of unprotected left main make the procedure very safe, simple, and effective. And this initial impression need to be confirmed. Thank you, everyone.
Thank you, Dr. Jamil. I know that you are expert in stents, but actually it's not available in everywhere. But let's speak again to, if you don't have a stents, this kind of stents which need some experience. I started a few years ago, but now because of the new stents, I'm trying to do different types and rather than this. What's the difference in tips and your tips and tricks in in doing DK crush?
I don't do DK crush.
Okay. Okay, you don't do DK crush, but you do tap. You only do tap.
Dr. Subhi, I'll tell you something. I have the ideal stent. Why would you like me to use bad stents? I mean, this is the ideal stent for left main bifurcation, unless there is contraindication or some kind. The most important contraindication is calcification. I mean, this stent doesn't like calcification, so you have to make the route for him. So I think this is the, I mean, when you see the 17 steps for the DK crash, when you have to cross, recross, kiss and to kiss the thing, you have a very simple procedure, a very effective stent. Okay, so it needs some training. Okay, it's a little bit difficult to master the.
Habib, put the name, and I'm speaking because they put the title is DK crash already. You should not ignore that something called DK crush, something called tap. So in just discussing, I'm not speaking about what you do. I'm speaking generally speaking. Let's go to that because this is the fellows course, not expert course. DK crush is if you have a short, if you have an angle less than 60 and good sizes, and then you put one stent in the side, two wires, the preparation, one stent in the side branch, and then kissing in order to crush some form of this first crush, and then remove the wire of the side branch of the balloon and put stent in the main branch, and then deploy, and then rewiring, crossing, kissing, and then second brush. I know these different steps, more than 10 steps, but sometimes it goes. You have already a try. The second is tap, is to have a wide angle, and it's easy, just like you say, you put a stent and minimal protrusion. The tips and tricks, the wiring. In the DK crush, you should do proximal, wiring should be proximal. In the tap should be distal wiring. And this, you can see it in the screen, the stent, boost stent. This is, I know this is not easy, but you can do this for the gel wire. You are expert in this stents. You don't find any difficulty in doing stents in your series?
Not really. I would like to have the opinion of Dr. Kamenzi regarding this particular point of distal strut and proximal strut. When using stentis, the old generation, the stent after delivering it will goes forward, and with this new generation, when you split the sheet, sometimes the stent goes back. So this story of distal strut and proximal strut, I mean, for me, is theoretical, because once you get access to the side branch and you inflate the balloon, your stent will move, and the cell will goes in front of the side branch. I don't know if it IVUS. Can you confirm this with IVUS, Dr. Kamenzi?
Well, I have no experience with these self-expandable.
No, it's regarding the whole any stent. I mean, once you deliver the stent and you put a balloon in the side branch, the stent is still moving. It's not fixed.
You know, Dr. Jamil, there is an Indian stent I'm using now. It's a long stent, up to 60 millimeter. And you have different size, 3 millimeter, 2.5, 3.5, 30, and also 4, 3.5. Do you think that this could be the future of lesion coming from the left main to the whole LED by one stent, not overlapping stents with different sizes? This is what we need in the future?
I don't know, but this is a good idea. I mean, we have this stent here also. It's from Merrill, I think. I don't know. There is no study, and I don't have a lot of experience with that. But the thing is, when you put a stent, a long stent, you have a lot of side branches, and you have to deal with these side branches. With the stent, you can disconnect the strut in front of each side branch. I have cases of trifurcation of left main, and with very, very proximal diagonal, also almost a quadrifurcation. And I disconnected the three branches without any problem. So this long stand, there is a problem with the side branches.
Okay.
I don't know the answer.
Dr. Jamil, also there is what known as foreshortening of the self-expanding stent.
Yes,
Foreshortening.
that's true.
It's usually.
Yes.
How can you treat this?
I mean, you cannot treat it. I mean, but the foreshortening exists also with the regular stents. I mean, there is a table, and you know that your stent is going to shorten. So when you decide to use that stent, you have to determine the size, the length of the stent before. You know, if you have a 20 millimeter lesion and you are going to use a 27 millimeter stent, for example, because you know that it's going to shorten. You should not use it.
Okay, case. Yeah. Guys.
I want just to ask you a question. Maybe what we see these days, that we have maybe a dedicated stent for left main, and even whatever is the solution, maybe self-extendable or two types of stent or two types of diameter. But we saw a long time ago also a different type of stent dedicated for bifurcation, but we never see really this stent use it at everyday practice. So I don't know, maybe that these stents are good for demonstration, but for everyday practice, we'll use always the same stent.
Yeah, there is problem. I mean, the problem of the stent is there since now almost 10 years. The problem with the stent is it's money. In France, it's not reimbursed. In most of the countries, it's not the reimbursement is not there. But you particularly for African countries, this is a very interesting stent because you don't use a lot of material. Imagine the amount of wires you have to use in Deca Crash, the amount of balloon you have to use in Deca Crash. You don't need IVUS for this stent. It's a self-expandable one. So in the malapposition studies, there is 0% of malapposition. The trunk stent, there is zero malapposition. So you don't need even IVUS. The stent will conform to the artery. So for our countries, even if it's a little bit costly than the normal stent, by the end of the procedure, you save money.
Okay, I think you are late 20 minutes because this is a very, very excellent symposium. Dr. Habib, Habib, you have a comment. You are the leader. You should have a comment. Unmute yourself, please. Unmute.
The self-expanding stent, expandable stent, we have been using that stent at certain time, and it has its own indication and advantages. There is no question about, particularly regarding the discrepancy of diameter between left main and LAD circumflex. It fits the diameter, but one of the limitations, Jamal, and I think you maybe you agree with this, is the fact that it moves exactly, and it moves more than the other stents. And one of the situation where actually it's not advisable to do it is, for example, the ostial left main, where you don't know actually where it goes. It goes back or forward, and then you can miss the lesion. So it has its advantages, but again, I don't think that interventional cardiology in general, you would have one single technique, one single stent that fits all. So you have to master few techniques. Deca Crash, it has its own indication, TAP 2, culotte sometimes. Stents, of course, as you said, but I don't think there is something that fits all the...
Habib, for this point, you are absolutely true. The old generation of has a tendency to go in Fatuto, but that was corrected by this new technique. This stent is not a self-expandable; it's a balloon self-expandable stent. I mean, you can precisely deploy the stent wherever you want, exactly like like the regular stent, and even the regular stent. Sometimes you have very difficult time to, as Dr. Awad showed, to precisely deploy the stent in the ostium. There is tips and tricks, and there is a lot of methods for that. But it's really the same for the stentis. The problem with this new generation is the retrieval of the sheath. It's really a very bad sensation. Sometimes you have to take it to employ strong force to remove the sheath, and in few cases, but not in the left main, this stent goes back. So there is some tricks to have to master the technique. I agree with you. You have to master everything, but I was a little bit provocative with Dr. Subhi when I said don't do the crash and don't do the tap. But this is because I mean it's really very easy to use. But of course, obviously there is lesions you have to do to use.
No. Sometimes you have a car and you like it, and don't change the car because you know how to drive it. You are the master.
Let's have a question for Dr. Sobhi and Dr. Awad, maybe, about the Diga crash. This is a good technique, and we know that you have good results, especially in the left main, but it costs a lot because we are using a lot of balloons. So sometimes we are attempt to do just one kissing, not two, just to manage two balloons, because the balloons have a lot of cost. We are using about five balloons for
regarding intervention.
If we skip one step, we can save two balloons, and sometimes it's working good. What do you think about this?
I tell you, I'm just a lesson to all my fellows. If you are doing intervention cardiology in the left main, do everything what you want. Otherwise, don't do it, because even a fresh balloon, don't use an used balloon. A new wire, not an old wire. Sometimes even bifurcation, use a third wire. So forget about the money about this. Otherwise, send the patient for surgery, because sometimes if you are confronted with a complication, you spend more and more, and the patient sometimes you are going to lose the patient. So a left main is a left main. It's completely different from bifurcation. I know it's a simple bifurcation, a big artery rather than the non-left main, but you have to, if you're doing the deca crush, do it properly. Otherwise, don't have results. I just disagree about repotting. Maybe repotting. I'm not sure of repotting, but already repotting, you have already non-compliant balloon, the same. So you have two wires or sometimes three wires. You have two balloons first. We have two non-compliant balloons, and that's it. You have 4 balloons, 2 to 3 wires, 1 guiding, 2 stents, and that's it. Cost of this, just it's a matter of peanuts, and you are going to see. Finally, thank you very much. I think I enjoyed personally. I have a meeting there. I leave the meeting because of Habib and you, and everybody's shooting me. I changed the schedule, changing the hours. But I really enjoyed it. Pafcic, thank you very much, Habib, and all my colleagues, and see you tomorrow. Goodbye.
We need to congratulate you, Mohammed, for your award today. Mohammed was awarded today the Lifetime Achievement Award from the Egyptian Society of Cardiology, and particularly the Society of Atherosclerosis, I think. So congratulations and well-deserved award, Mohammed.
Thank you.
Okay, very good. Thank you very much. The last session will start in 5 minutes, and it's a symposium, Sanofi symposium, so you can join us.
Thank you.
Thank you very much.